And now I'd like to introduce Dr. Singh from City of Hope. He is the head of Hepatobiliary and Pancreatic Surgery, HP for short, as I've learned from surgeons, and the chief of Division of Surgical Oncology, Department of Surgery, Vice Chair, Department of Surgery at City of Hope. Please welcome Dr. Singh.
Thank you, Giovanna. Welcome to City of Hope. I'm going to do a one-day conference in 15 minutes, so we're going to go on a quick roller coaster ride here. All right, so as we already talked about, often alluded to as carcinoids, which is actually still neuroendocrine tumors, 70% of them come from the intestine, so midgut. 30% of those come from the pancreas. They do end up in the liver as the first station, usually, because of this big vein that Dr. Nissen just showed you that drains the entire intestine, brings it to the liver filters this blood, and then returns it to the heart on the top over here. So we do see a lot of liver metastases in neuroendocrine tumors. Often, they are the first diagnosis. So in the actual spectrum or the length of disease, a patient with neuroendocrine tumors, usually they develop 5 to 7 years into the tumor being there. So taking the primary tumor out here is always a good thing if you can take it out. Often they present with just a liver metastases, and a biopsy of the liver metastases points you in the direction saying this is a neuroendocrine tumor and possibly arising either from the midgut or the pancreas or the colon. Not always, but often. And so, as you know, a lot of the patients with neuroendocrine tumors are usually asymptomatic. They have vague abdominal symptoms, and they're actually ignored for almost 5 to 10 years till somebody decides to do a few additional testing on this patient population. And one of the two symptoms which I think are key is flushing when tumors actually end up in the liver and become functional. Not all tumors. A small percentage of these tumors will become functional when they get to the liver because they start secreting certain hormones, which makes you red. And so the flushing here is classically different from perimenopausal or postmenopausal flushing. This is no sweating in this one. So they turn red often on their own, a couple of times during the day. Sometimes with a sip of alcohol, they become red. So this is the classic flushing associated with carcinoids. And the last thing, the second characteristic thing is they start developing diarrhea, but they usually get up in the night to go for a bowel movement. So that is very unusual. Most people will be able to sleep through the night. But if this is happening, you are kind of looking at a symptomatic neuroendocrine tumor. Now I'm going to go through pictures just to give you an idea of what I like and what is out there. Of course, the gold standard used to be an octreotide scan, which shows activity in the tumors, not as sensitive, not as hot, is rapidly being replaced by now the gallium-68 scan. So the gallium-68 is a sophisticated version of the octreotide scan with far higher sensitivity and the ability to get CT images at the same time. So now you can see the metastases within the liver, you can see the metastases, you can see a nodal metastases here, and you can also sometimes see the tumor within the intestine itself. Now we weren't able to see this 5 years ago. I say even 3 years ago, we didn't have that ability to see this. So for the people who are out there with unknown primaries, it stands to consider getting a gallium-68 scan, which might point you towards the direction of where that tumor is arising from. Not 100%, but at least may give you a little bit more information than what we have. From a surgeon's perspective, I like a good quality CT scan, and I like a good arterial phase. I like to see the tumors light up within the liver in the arterial phase. And my favorite now is, of course, the MRI, and I like it specifically for neuroendocrine tumors when you use the EOVIS contrast because it differentiates even subtle findings and differentiates and tells you whether that's a tumor or not a tumor sitting in the center or in the side of the pancreas. So you can pick up not only the big main one, but you can pick up subtle smaller ones which you may not see in a CT scan. So with that introduction, I think management of liver metastases is a team sport. And as you can see, this is our team here. Surgery, medical oncology, Dan Lee's here, interventional radiology, interventional gastroenterology, radiation oncology, and of course research. And actually, believe it or not, our scientists are here today too. John Williams, David Colcher, Jack Shively are in the audience today. And there are a couple of postdocs also actually sitting in the audience today. I just started. She's already given me the 5-minute sign. All right. All right, so with that, how do we manage these? So if these tumors are operable, the gold standard is to take it out. But it's a difficult thing. You need to come up with a strategy to be able to operate on these tumors. So not only is it important to get the primary, like Dr. Nissen just mentioned, and get the nodal mass, I think removing the liver metastases and removing the gallbladder are mandatory. Gallbladder is especially important in these patients because they have contractile dysfunction with the use of octreotide or somatostatin, and patients tend to develop cholecystitis, stones, et cetera, et cetera. So at the time of surgery, it is one of those things that we made it a prerequisite that most patients with neuroendocrine tumors should also have their gallbladder removed. Now, as you will see, there are a lot of different modalities of treatment. And surgery, ablation, tear, or transarterial radioembolization versus selective internal radioembolization with the same thing, transarterial chemoembolization, and the others. And I'm going to hit on what we as surgeons look as in planning therapy on these patients and how we approach this. So when you see multiple tumors like this, and as these patients actually, believe it or not, all I'm showing you are in the audience today, and I'm not going to tell who they are, but just so that you get an idea. Then the most important thing here is you've got tremendous amount of load here. You know that this liver is extremely difficult to deal with. But guess what? She's got a primary, or he's got a primary tumor within the pancreas. So taking out the primary tumor slows down the progression of metastatic disease. This patient also got 2 rounds of selective internal radiation with Y90 beads, which is yttrium-90. And what we've shown here is, again, that resection of the primary definitely leads to a survival advantage. Resection of the primary and the metastases is far superior to anything else that's out there. So again, point I'm trying to make is surgery is the gold standard when it's possible. This is all our data again. This is, we presented this last year at the Society of Surgical Oncology. Again, the removal of the primary versus those that are not removed, what happens to patients in the presence of liver metastases. And you will see that all of them have a survival advantage, whether they're removal of the primary in the small bowel, colon, or the pancreas. The only one that didn't have a survival advantage was stomach, and we think that that's primarily because the volume of patients was very small in our study cohort. We looked at about 864 patients in the California Cancer Registry. And again, with this and removal of the, with liver treatment, you still give them the best survival advantage in this patient population. Again, 864 patients that we presented last year at the Society of Surgical Oncology. This is a quick overview to tell you about the modalities that Dr. Nissen was going to touch on. Radiofrequency ablation versus microwave ablation. Radiofrequency is on its way out. Basically, you put a needle in, it burns the tumor. Microwave, it doesn't actually have that starburst appearance anymore. You can put it into tumors and you can burn the tumor. Remember, ablation is safe for tumors below 3 centimeters in size. Above that, you have to think about leaving a big hole that's burnt tissue within the liver. So again, you have to balance it out. You can do it, but you have to be cautious. You have to plan it well. You need to make sure you're not doing 10 different ablations at the same time. Otherwise, you end up with problems. And those problems end up getting referred to us here at City of Hope when people have done these indiscriminate ablation in this patient population. Cryotherapy, as I mentioned earlier, is basically making an ice ball. The recurrence rates are as high as 66%, so that's really fallen out of favor. The new technology is nanoknife or irreversible electroporation. It's passing current from one side to the other. You give 90 pulses, it disrupts the tumor. Again, The advantage of this now is if you have tumors located critical areas around a blood vessel and you know you can't take it out safely, you can put this around the blood vessel and still ablate the tumor, and anything with blood flowing through it is not going to get affected by the ablation. So it still preserves the integrity of the blood vessels and actually selectively ends up bursting the tumors. Again, this is currently approved for tumors less than 2 centimeters in size, and we occasionally use it for more as we travel along certain areas after a resection or during resection. And then Y90 is yttrium beads, which are radiation beads, which are kind of injected into the tumor. These basically go and sit in the tumor, and they basically start working. Its radiation half-life is about a day and a half to 3 days, somewhere in that range, and basically ends up killing the tumor. I will tell you that smaller tumors respond beautifully. Big tumors, 5, 10 centimeters, you may get some size reduction, but you do not get complete disappearance of those tumors, and so you need to plan for additional treatment. So if you have a big tumor like this, and you think you can safely resect it, the gold standard is surgery. But if you have a tumor that is much bigger than that, then you need to downsize this tumor using various modalities, which would be either systemic chemo or TARE or chemoembolization, and I'll talk about portal vein embolization in a second. We also end up doing what are called multiple enucleations. You really don't need a margin on these tumors. You can just shell them out like you're shelling a hard-boiled egg almost. And so you can get, as long as you can bring it out with between the liver and the tumor itself, you can actually shell these out, getting their main arterial branch as you get down to the base of the tumor on these. Now, it is incredibly difficult when you have multiple tumors like this. And what you can do in this sort of a situation is you have to plan out. Here you're going to leave this patient with very little viable liver in between, and then how do you know there's no microscopic disease in here? So we as surgeons have developed strategies, and some of the strategies we've developed are called portal vein embolization. You can block the flow. This is 2 liters, 1.5 to 2 liters per minute going into the liver. If you block the flow, this 1.5, 2 liters is now going through the left side, leads to a compensatory hypertrophy of the left side by 8 to 13%, making my surgical resection now safer, and I can go ahead and now take it out, giving me more volume that I'm leaving behind on the inside. And then last but not the least is doing it in 2 stages. You can take out the smaller portion, allow this portion of the liver to regenerate. It's one of the few organs that regenerates almost close to 100% in volume in 3 months, and then go back and take out the remaining portion of the tumor. I wish it was as easy as that. It's not always that cut and dry when you look at the liver and the tumors, at the distribution within the liver itself. What we're really looking at is how do we prevent liver failure from the burden of disease within the liver. And there are some patients we just can't offer them surgery, so we have to think a way to actually prevent that liver metastases from taking over. So there are several strategies, and we do develop them trying with the intent of being able to do. Most often we win, but not always. We try our best at all of this. So again, this is neuroendocrine tumors. As you saw earlier, you can take this off uneventfully, and then you can actually enucleate these tumors on the other side with just coring these tumors out. Now, this is just a quick example of multiple liver metastases which you see within the liver. We actually block the portal vein. This is done as an outpatient procedure. Now the selective flow to the left side, and then we go in, resect the right side, and then do a couple of resections on the left side, and still able to leave this patient tumor-free. We've also now started doing a lot of these minimally invasive and robotics. Now, I want to caution you, if it's a big tumor, there's no way you can squeeze it out of a 1 centimeter incision, so that needs to be taken with a pinch of salt. You have to think about robotics and minimally invasive surgery for smaller tumors, for single tumors, or maybe 2 tumors, but you can't do it for 20 tumors within the liver. It's not a feasible modality at this point, although I think it is the force of the future. And again, I'm going to go through real quickly through that, again, pointing out to you, this is again our data looking at 3,900 patients in the California Cancer Registry, showing that if you are able to achieve liver resection in this patient population, you do give them a positive advantage, even liver-directed therapy, and of course removing the primary tumor along with it, it gives a very positive outcome and longevity in this patient population. So the question is, what are you going to do for these tumors? Now I'm going to put up 3 examples here, again, patients in the audience, just to give you an idea. You have a single metastases here, you have a big metastases here with the pancreas, that kind of Dr. Nissen showed you, and then you have another big metastases here. So the reason you would go after this one here is because you can see the main blood flow coming into this side of the liver is going to be occluded by this tumor going forward. So you want to prevent that from happening. So our focus is going to be on this, not on these smaller tumors. If you incidentally clear the smaller tumors or you ablate them, that's fine. But the focus is sometimes on the bigger tumors and where it is located. Now, so all 3 of these got surgery. As you can see, this one is surgically resected, done well. This is also surgically resected, again, after the liver is regenerated and the primary was removed. And this also, the central portion's been resected, and you can see that there's a good control now, good flow to the remaining portion of the liver that's left behind. One other thing I do want to bring to your attention is we look at a scan and we see this tumor and we see this tumor and we see this tumor and maybe this tumor, but we don't see all these other tiny tumors on a scan. Resolution of 2 or 3 or 4 millimeter tumors is not possible even with the best of modalities today. Whether it's gallium-68, whether it's an MRI, whether it's a CT scan, when you get in there, you are not going to be able to tell this on preoperative imaging. So again, it is important to remember it's always more than that meets the eye when we get inside. We focus predominantly at debulking the liver between 70 to 90% if we can achieve it, and that's what we focus. Or we stage our debulking, or we develop an algorithm where we think we will be able to beat this disease. Now you look at this liver, clearly there is no way to be able to eliminate all this disease. We need better modalities of therapy to be able to beat this. And so this patient got 2 rounds of selective internal radiation, which is Y90 or yttrium beads, and she's 5 years out now, doing well. Now, what is happening in the community, and which is what I'm going to caution you about, is all these radiation treatments are beginning to stack up. We're seeing Y90, we're seeing lutetium-177, and nobody's thinking about the damage that is happening to the liver. And this is what I'm seeing now. So this is a patient who got Y90, then went abroad, got lutetium-177, and overdone the treatment in this case. So this patient's liver is shrunken, it is cirrhotic, and there's fluid all around this. So again, I think it's very important because we didn't see this 10 years ago. These are all new therapies. So my way of looking at this is wisdom, caution, go slow, don't rush into it. Because it's going to, we think it's going to cure it, don't rush into it. Because remember, this is all radiation beads getting into the liver. Even though it's focused at the tumor, there is collateral damage to the normal liver. And so that's why I think you need to exercise caution. So when I see somebody like this with 2 little dots over here, I say don't overreact. Just go with the flow. It's probably going to take 15 years or 10 years before this gets manifest. So let's just take a deep breath and follow it. You can do a whole host of other treatments, but you don't want to start using radiation or ablation or right off the bat in these patients. So again, there is some merit to observation. And that's my last slide. So again, if you can debulk 70 to 90%, that's the way to go. And again, there are a lot of new therapies coming out, and I think we will discuss this during the course of this conference. Thank you very much.